So I just want to give you a little bit of an introduction to the pulmonary rehab, how it came into being, why it's important that the program of pulmonary rehab is utilized. You'll find that a lot of the government programs have kind of cut out pulmonary rehab over the years because it's not a major moneymaker. It's one of those things, it's a side program. A lot of patients benefit from it, but it doesn't make a lot of money overall for the facility or hospitals. A lot of regulations behind it, and they have to do things a certain way. The history behind why it became important was we have a very large growing generation of COPDers. A lot of patients smoke and they end up with what we call end-stage COPD. Their life is very limited. Some of them are on oxygen 24 hours a day, 7 days a week, and they have very limited mobility as far as a lot of psychosocial issues. They're very anxious. They're always short of breath, and they're having repeat admissions to the hospital. So back in 2010, they came out with what was called the Patient Protective and Affordable Care Act. And it was a program that was designed to help try to get these patients in order so they don't have to keep having repeat admissions to the hospital because they're having trouble. If they can have a program outside of the hospital that can have early intervention, teach these patients how to breathe better, how to manage their breathing when they're short of breath, they may not have readmission so often to the hospital, causing the hospital lots of money for repeat care. So the Council on Rehabilitation, which was one of the areas that came out with this program, defines rehabilitation as the restoration of the individual to the fullest medical, mental, emotional, and social and vocational potential of which he or she is capable. So our goal is to try to get our patients back to their baseline where they can function, be productive in society, and be able to manage their disease, whether it be chronic bronchitis or COPD, emphysema, or a combination of those conditions. Their overall goal is to maximize functional ability and minimize the impact disability has on the individual, for their families and the community, because everyone is involved. Everyone's taking care of the patient in some kind of way, whether it's the doctors in the clinics, whether they're going to a rehabilitation center, or they're having repeat hospitalizations where they need extensive care. I can think back many a times where I worked in the emergency room, and it was just like clockwork. We always had the same, what we call repeat admissions of patients that were COPDers. They didn't manage their breathing well. They ran out of medications, whether they just couldn't afford it, and they would come through the door and basically say hello to me because I knew them and they knew me, and I knew exactly what they needed when they came in because they were in an exacerbated state. So these pulmonary rehab programs, the design of them to help with early intervention with patients breathing, to help them learn how to manage their breathing so they don't keep coming into the hospital, is essential. And they've really cracked down on it even more recently to prevent readmissions by penalizing the hospitals as well when they come back. Pulmonary rehabilitation, according to our reading, is the art of medical practice wherein an individually tailored multidisciplinary program is formulated which through accurate diagnosis, therapy, emotional support, and education stabilizes or reverses both the physio and psychopathology of pulmonary disease. So it's a collaborative effort with an interdisciplinary team. You're going to find doctors, nurses, of course, respiratory therapists, and the dietitian with physical therapy also working together to come up with the best plan for this patient to get them back to a state where they can function and have a decent quality of life. So what are our goals of pulmonary rehabilitation? Of course, we want to be able to control and alleviate the symptoms for the patient, teach them proper breath control, how to do diaphragmatic breathing. This helps to alleviate some of the symptoms, helps to calm the patient down, at least until they're able to get the medications that they need on board or get them into the proper setting to get the care that they need. And we want to restore functional capabilities of the patient when they are really in the exacerbated state, or what we call end-stage COPD. Their capability to be productive in life is really hindered. Some patients say they can't even hardly walk to the bathroom without being short of breath or having to stop on their way halfway to the bathroom to catch their breath.
And then also, we want to improve the quality of life for these patients. Get them to a state where they're able to function and just be able to go to the grocery store or, like I said, go to the bathroom without being short of breath, to get up and just do the daily activities of living, of washing dishes or being able to drive. Our overall goal is just to attempt to return the patient to the highest possible functional capacity allowed by his or her pulmonary handicap and their overall life situation. So some of these patients, they won't be able to do as you and I, be able to walk long distances or be able to just do everyday errands. But if we can get them back to at least their baseline where they're able to function and be able to socialize and go out and have fun with their family and friends and be able to do some activities of daily living as far as taking care of themselves, then we've done everything we can at least to give them a decent quality of life until their lung condition gets to the point that it's not treatable anymore.
So on the previous slide, I just kind of gave you some general goals of the overall scope of pulmonary rehab as far as what we want to do to get the patient better. But in box 50-2 that's in this slide, I wanted to give you a list of just more common goals for pulmonary rehabilitation programs. So ideally, we want to be able to control the patient's respiratory infections, because if they get infection, they get sick, their breathing gets bad, they're back in the hospital. Also work on their basic airway management, making sure the patients have the nebulizers they need, the pulmonary steroids, corticosteroids that they need to keep their breathing good, making sure they're seeing the doctor like they should regularly to make sure their breathing is being managed properly. If they wear CPAP or BiPAP, making sure that they have the equipment that they need for home to prevent readmissions to the hospital because their breathing gets a little bit out of control. So the next bullet point talks about improvement in ventilation and their cardiac status. So in the pulmonary rehabilitation programs, we're exercising the patients, getting them stronger physically, muscle-wise, and lung-wise. We want to have improvement in ambulation and other types of physical activity. We want to overall reduce the medical costs it takes for the readmissions. If we can keep their breathing good, teach them how to educate the patient on how to better take care of their breathing, making sure they have things on board, know their warning signs early, it can lower the overall cost of the patient by reduction in hospitalizations. We want to make sure to retreat their psychosocial support, making sure they're getting the mental health aspect is taken care of. They may need to see a psychologist because a lot of these patients are extremely anxious. They may need to have Ambien on board or other psychosocial medications to make sure they stay calm, because if the patient gets short of breath and have a hard time breathing, they get anxious and their breathing shuts down. Occupational restraining and placement when and where possible, making sure that they have the tools that they need for home, whether it be a walker or the bedside commode, so they don't have to get up and walk too far. Just making sure they have the tools they need to be successful in the home environment. Educating the family, making sure the family understands the treatment plan, how what to do if the patient gets short of breath. It doesn't always mean go straight to the hospital. What is it that you can do at home to try to get the symptoms and the problems that the patient have down before the need, if you see the early warning signs before the need to go to the hospital. Providing the family counseling and support as well as the patient education, counseling, and support. Working together, they can have a good treatment plan to make sure they're aware of the things that they need to do to have success in the home environment. And like we said before, just overall controlling everything. Warning signs, if the patient's coughing up secretions and it's looking yellow, that's an early warning sign that maybe they need to see the doctor. There may be an infection brewing. So this overall patient care education to prevent readmission to the hospital. Just want to give you a little bit of history behind the making of rehabilitation programs. It was as early as 1952. This is not by any means a new concept. Back in 1952, it was recognized by different scientists and researchers that these patients with lung disease, and the whole concept of lung disease was even new, They needed to be some type of intervention for these patients. They were finding patients that had smoked and had early diagnosis of lung disease, were having a lot of trouble just walking and doing typical functions in life. So Barash and colleagues, these scientific researchers, recommended reconditioning programs for patients with chronic lung disease to help improve their ability to walk without dyspnea, even way back in the day. But a lot of the clinicians and doctors really didn't pay much attention to it. The trend and treatment back in that day was to put people on oxygen and put them on bed rest. Bed rest was the solution for everything. Even women that had babies in the hospital were on bed rest for weeks and weeks and weeks. And what they found was through research and studies that patients that were on bed rest did not get any better. Their skeletal muscles started to deteriorate. They started having more progressive weakness and fatigue. Their levels of dyspnea actually got worse. And these patients not only had more shortness of breath, but they became homebound, where they couldn't go out and function in society. And some of these patients even became bedbound and couldn't get up and do anything. So it became recognized very early on that another method or treatment plan needed to come about to help these patients become more successful in just daily life. So in 1962, another group of researchers, Pierce and Associates, observed that the patients with COPD who participated in physical reconditioning exhibited lower pulse rates. They had better respiratory rates, minute volumes, and their CO2 production during exercise was a lot lower. So they're recognizing, there's benefits to doing some physical reconditioning. But the other side of it was they found even though we're doing all these things with the reconditioning, it doesn't do much to change their overall lung condition. We can make them stronger, we can help them have more endurance, but when they did pulmonary function tests, their volumes and lung capacities and all that didn't change much. So they were learning early on the limitations and the benefits to doing reconditioning. In 1967, Perez and Associates, more researchers showed that reconditioning could improve the efficiency and motion and O2 use in patients with COPD. The efficiency and motions of patients with COPDs. So subsequently, Christie showed that the benefits of reconditioning could be achieved on an outpatient basis with minimal supervision. This work was also extended into 1968, where other investigators continue to research the benefits of the pulmonary rehabilitation. And evidence, even in our present time, indicates that pulmonary rehabilitation benefits patients with chronic lung disease, and not only that, restrictive diseases. And then they came out with even another step further. They found, well, instead of us always trying to find ways to make their lives better, why don't we just try to squash it all together and teach the patients smoking cessation. Smoking cessation deals with trying to teach the patients early on to just not smoke at all. Get them in groups, support groups, give them medications to kill the cravings and just stop the smoking and the lung progression of the disease itself altogether. If you can stop the smoking early enough, the patient's lungs can heal. Sometimes it can take as long as 10 to 15 years, but their lungs can heal, and then we can just prevent this whole situation from the beginning if we can just get the patient to stop smoking. You'll find a lot of times in the hospital, the doctors will order smoking cessation, and some patients are receptive to it and some of them aren't. They'll just flat out tell me when I try to teach them educational smoking cessation, if it's ordered, I enjoy smoking. I want to smoke. I don't want to quit. And they're adults. They can make their own decisions. But we ultimately, because we are respiratory therapists, want to encourage the patient to quit smoking because their overall lung function and health will be better in the long run. So rehabilitation must focus on the patient as a whole and not solely on the underlying disease. For this reason, effective pulmonary rehabilitation programs combine knowledge from both the clinical and social sciences. A lot of research goes into what can we do to try to make our patient better. Well, one way they found was through physical reconditioning. Physical reconditioning deals with exercising the patient, getting their muscles strong, getting their lungs stronger. But this physical activity also increases their energy demand. So it's very important that these patients have proper nutrition, making sure that they have enough oxygen on board so they can do the activities that are needed to get them stronger. If the patient has poor conditioning of the muscles, it's going to lead to ineffective use of oxygen and excess acid production. So we find these patients when we just take care of them in general and we do a blood gas, they're very acidic. Their CO2 levels are high, especially when they haven't had treatment in what we call the 50-50 club. Their CO2 is in the 50s, their PaO2 is in the 50s. These patients need oxygen, they're dyspneic, and they're short of breath. So pulmonary rehab as a whole aims to recondition the muscles and increase their exercise tolerance so they can be more productive in just daily life. So in figure 50-1, you can see what the overall body response is to exercise. From the illustration, you see that everything increases: tidal volume, respiratory rate, stroke volume, pulse rate, ventilation and perfusion increases, increased vagal tone. It's just overall beneficial altogether for our COPD patients to exercise their lungs and their muscles. So ventilation and circulation increase to the supply tissues and cells with additional O2 and to eliminate the higher levels of CO2 produced by metabolism. So that's very important for our patients because our patients with COPD, they're not ventilating well to begin with. They're short of breath. Ventilation is impaired, and a lot of times when we do the blood gas, we find that these patients are what we call the 50-50 club. Their CO2 is in the 50s, their PaO2 is in the 50s. So exercise will help blow off a lot of that unnecessary CO2 that's in the body and overall strengthen our patients. So these patients at rest, individual maintains homeostasis. Homeostasis means trying to keep everything in balance, whether it's internal, external, and cellular respiration. So when the patient has exercise and physical activity, it increases the overall energy demands. Everything's out of whack, and the body has to learn to modify to keep up, to get stronger, and improve the breathing so the patient can have an overall improvement in their health. So to maintain homeostasis during exercise, the cardiovascular system must try to keep up and maintain a certain pace so the patient can get stronger. So you can see in these figures, we have a point A and a point B in the graphs, and these points represent O2 consumption and CO2 production. Also increase, as you can see, in a linear fashion as exercise intensity increases. So if the body cannot deliver sufficient O2 to meet the demands of the energy metabolism, blood lactate levels increase above normal. And in exercise physiology, this point is called the onset of blood lactate accumulation, also known as OBLA. As this excess lactate acid is buffered, CO2 levels increase and this stimulus to breathe increases. The result is an abrupt upswing in both the CO2 and the minute ventilation. This is also referred to as what we call ventilatory threshold. So beyond this point, metabolism becomes anaerobic and the efficiency of energy production decreases, and the lactic acid accumulates and fatigue sets in, as you can see from the graph. So what are the factors that limit a COPD patient? Patients with COPD who lack adequate pulmonary function have severe limitations to their exercise capabilities. Their high rate of CO2 production during exercise results in respiratory acidosis and a shortness of breath out of proportion to the level of activity that they're doing. So in addition, as ventilation increases, the rate of O2 consumption in a patient with COPD increases significantly as depicted in our previous slide. So together, these factors limit patient tolerance for any significant increase in physical activity. So what we've talked about so far is exercise, how it affects the patient, especially a patient with COPD or some type of lung disease or restrictive condition, how it affects the body overall with the ventilatory threshold and other functions in the body as far as increasing tidal volume, respiratory rate, pulse rate, increased cardiac output. But there are many different types of benefits, whether unproven benefits, potential benefits, or what we call accepted benefits. So pulmonary rehabilitation must include efforts to recondition patients physically and increase their exercise tolerance. So when we're talking about reconditioning, that involves strengthening essential muscle groups, improving overall O2 utilization, and enhancing the body's cardiovascular response to physical activity, as noted on the slide. In your book in Egan's, there's a box on page 1266, box 55-1, that has a whole list of benefits from reconditioning. Be sure to familiarize yourself with these listings because you're going to see them again on your test. So in your book, it talks about accepted benefits, potential benefits, and what I don't have listed on the slide is unproven benefits. So when we're talking about accepted benefits from exercise reconditioning, we're referring to increased physical endurance, increased maximum O2 consumption, which we've already talked about. It increases the overall activity levels for the patient. Within decreased ventilation, decreased O2 consumption, decrease heart rate. Eventually, all these things are going to happen. Increase ventilatory threshold and improve blood lipids. So these are the overall benefits from having therapy, doing therapy. Long term, you're going to see these changes take place as they continue to get this kind of treatment plan. Other potential benefits which are listed in your book is the increased sense of well-being, improved secretion clearance because they're deep breathing and coughing, increased hypoxic drive, and improved cardiac function because they're exercising, the heart's going to pump and it's going to get stronger. And then also we have unproven benefits from exercise reconditioning. Like we said before, pulmonary rehab does not do anything for their lung condition. It's not going to make their lung condition any better. If they've damaged their lungs are going to continue to be damaged. So it's not going to prolong their survival. If there's damage on the inside, there's nothing we can do. But what we can do is strengthen their body and try to give them a better quality of life. That is our goal. It's unproven that it improves pulmonary function test, PFT. So if they do a test, we're not going to see any changes with that. Decrease pulmonary artery pressure, unproven. Improve blood gases, not really proven, but we know from the exercise it will decrease their CO2 levels, but will it last long term? We can't really tell. It's not proven at all. It depends on their lifestyles, what they're doing, how compliant they are with their care. Change in muscle O2 extraction and change in step desaturation. So all these different things are stuff do we have to consider. Acceptable benefits. What is the most prevalent symptom that limits, interferes with activities of daily living, which is called ADL, of a patient with pulmonary disease? So to answer the question from the previous slide, according to the American Thoracic Society, dyspnea is what limits the patient and interferes with their activities of daily living, which is called ADLs. Dyspnea is defined as a subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity, and recommends evaluating dyspnea by assessing the intensity of the distinct sensations, the degree of distress involved, and its burden or impact on activities of daily living. I'm going to stop right there with the whole explanation on dyspnea. Your lesson for next week is going to go more thoroughly into the whole dyspnea thing, what causes it, what do we see it, how do we see it in our patients, and how do we treat it, or at least try to alleviate the symptoms. This concludes the lesson for this week. Be sure to review all your materials from your reading assignment as well as your PowerPoint. That's going to help you prepare for your quiz. I cannot emphasize it enough. Please do not go and try to take your quiz and wing it. There is information that you need to have in memory to be able to successfully pass your quiz. Next week we're going to talk about dyspnea. I will see you next week, and good luck on your test.